I welcome you all to this interesting and important session on intensive care in hepatology. First, I'd like to introduce the speakers. I would request the chairpersons to grace the stage. Dr. Ashutosh Mohapatra, Dr. K. Madhu, Dr. Umesh Goyal, Dr. Praveen Sharma, Dr. Rakhi Maiwal, and Dr. Sandeep Thareja. Now I request the chairpersons to please introduce the speaker.
So let us start the session on intensive care in hepatology. Now invite Professor Dr. Epen from CMC Vellore to deliver the talk, sir. He'll be talking on plasma exchange in ACLF.
I invite Dr. Amit Singhal, gastroenterologist, to kindly chair the session.
Good morning, friends. Thanks for turning up for this session. So I'll discuss a bit about plasma exchange to treat liver failure. This is known by different acronyms. We call it PLEX because that's easier on the tongue to pronounce. Now, this reality is PLEX is increasingly being done in different centers in India. And the sense I have is more and more centers will be doing it if it's not yet being done. So what is plasma exchange? Basically, there are two steps to this. One is to remove plasma from a person who's in a state of ill health and to replace that with a fluid. In liver failure, the replacing fluid is fresh frozen plasma or FFP. So plasmapheresis plus replacement with this fluid is together termed as plasma exchange, and we call it PLEX. Now for liver failure, there are different volumes of plasma which can be exchanged per session. In what's given at the bottom, in an adult, we all have 5 liters of blood volume in the body. Half of that is plasma. Let's say it's 2.5 liters. So the 3 different volumes which have been used are, one is high volume, which is 4 times the plasma is turned over per day, exchange per day. That is by the study from landmark study by Larson et al. And in standard volume, which is 1.5 to 2 times the plasma volume, while mostly at CMC, at Vellore, we have been using low volume or half the plasma volume per day is what we have been using. So I'll cover PLEX in patients to treat patients with acute liver failure as a first part. So this was the landmark study from Europe where high volume plasma exchange was a randomized control trial and was used over a 18-year time frame of patients with acute liver failure. And they could show that there was a 10% increase in survival in patients who could not undergo a liver transplant. So that was where the pronounced improvement maximum improvement was noted in that group. Now, based on the outcome of this RCT, the American Society for Apheresis has now recommended that high volume plasma exchange can be considered a standalone first-line therapy for ALF or it can be used along with other treatments for ALF. So that is the basis of this recommendation. Now, this study by Dr. Raki Maival and team from ILBS have reported that standard volume plasma exchange is also safe and improves survival in patients with ALF with cerebral edema. Now, in Tamil Nadu and in southern parts of India and western India, rodenticide ingestion is a fashionable way of committing suicide. It contains phosphorus. And in this study conducted in 2019 by the Tamil Nadu chapter of the Indian Society of Gastroenterology, we could show that across Tamil Nadu, for every one patient with paracetamol overdose causing liver toxicity, there were 75 patients who consumed rodenticide as a suicidal agent. And in the study, we could show that majority of the people were young, and 1/3 of the patients died or were discharged in a terminal condition. And of this 450 patients, this study was only in 2019, only one patient underwent liver transplantation. Now, this is the ground reality when you look at it from this angle to the access for urgent liver transplantation. So this is a bit like this familiar picture that most people in the slums who are living in India can only look at the plane, but they are not actually flying on the plane. So Dr. Acharya has put out in this article that of the 1,000 liver transplants per year, 5% to 7.5% is done for ALF. That means per year, 50 to 75 patients only are able to access urgent liver transplantation. So there's a dire need for some other modality of treatment for these patients. Now I'll focus on rodenticide poison a little bit. Now this criteria, we are now calling it the Kochi criteria, was described by Amrita Kochi group in 2015, where from their data set of patients with rodenticide and liver damage, induced liver damage, they could arrive at some criteria. And when patients met those criteria and had standard medical therapy, none survived. While if they underwent urgent liver transplant, 86% survived. In our data set in Vellore, of the patients who were eligible for PLEX, we could find, of course the numbers are very small, but those who met these criteria and none of the families opted for urgent liver transplantation, the survival across all age groups was 62%, and those in a younger age group was 75%. So increasingly it appears that this therapy is saving lives. In fact, there's an editorial accompanying this article in JCH by Larson, who also is appreciative of the fact that even low volume plasma exchange seems to be working in patients with ALF. The Tamil Nadu chapter of the ISG, which conducted that important study for us, has now brought out some guidelines when to do PLEX and when is PLEX contraindicated. This incidentally are, as of now, the world's first guidelines for the use for PLEX in any form of acute liver failure. So, though this is specifically for rodenticide, I believe this is generalizable and would apply to all patients with ALF or severe ALI, acute liver injury. In this particular conference, Vijay Alexander from our team has presented a poster that when we see the reduction in the MEL scores on plasma exchange therapy in these patients, one could predict those who are likely to survive or not survive. For example, a more than or equal to 10% reduction in MEL score while on PLEX could predict survival. So this may help us in deciding which patient needs to go for liver transplant or not. So this is a dynamic score which may be helpful. I'll move on to ACLF. Now in ACLF, I think how I would approach is try to understand what's making this patient so sick, look for the etiology, and if there are any treatments we can use to address that, I would do that. Consider PLEX. I would do PLEX earlier in the illness and consider liver transplant a little later in the illness, who are more severe disease. We know that by the APASL and ESL, the two most popular ways of defining ACLF, Dr. Sareen talks about a golden window period where the person is in what's termed as sterile inflammation. There's no infection as yet. And that's a good time frame to aim to do treatments like plasma exchange. This very recent study from across Europe, where the experience of using liver transplant to treat acute liver ACLF, 25% had grade 1 ACLF and 33% grade 2 ACLF. So it's our proposition that increasingly grade 1 ACLF, one can try treating with plasma exchange, while grade 2 and 3 probably will need liver transplantation. So the initial analysis of severe alcoholic hepatitis patients who also met criteria for ACLF with the APASL score, we could show some differences in survival between the standard medical therapy versus PLEX, though it doesn't look very impressive. The survival curves are just marginally different. This came out last year in JCEH. But now, our further analysis show that if we were to analyze them as to patients who underwent centrifugal type of plasma exchange versus membrane type, then the survival curves start to different. Now, usually membrane type plasma exchange is what is offered mostly by nephrology specialists, while the centrifugal type plasma exchange is what is usually done by the blood bank and transfusion medicine departments. So when we do propensity score matching on this data set, that again holds good. The centrifugal plasma exchange seems to have clearly a better survival compared to membrane plex or compared to standard medical therapy. And as you can see, now we have patients who have crossed 3-4 years of follow-up, and they remain well. So what are the differences between centrifugal and membrane plasma exchange? We do not fully understand it, but we think the importance is with the flow rate. And if the flow rate in the centrifugal type is a very slow flow rate, and that does not disturb the patient's hemodynamics so much. And we think that is a crucial difference in this group. So when patients with very severe alcoholic hepatitis, there are the definitions for these using the DF score and the MEL score, and when they undergo plasma exchange, immediately we are trying to see how do the severity scores pan out. And as you can see, with the centrifugal plasma exchange, there are some more and more patients where the severity of inflammation seems to be coming down, and they move on to the severe or moderate severity of alcoholic hepatitis. When we did a multivariate analysis of predictors of 1-year transplant-free survival from our data set in 51 of these patients, we could show that if we were to use centrifugal type of plasma exchange, as well as if there was a decline in bilirubin while on plasma exchange, that could predict 1-year survival. So specifically on bilirubin, by day 2 or 2 sessions of PLEX, if there's a drop in bilirubin by 10% or more, then the chances of odds of surviving 1 year is very high. By day 3, it's almost like it's infinity. The odds ratio is pretty strong there. So such indices may help us decide which patient should we take up for transplant or which we do not, or maybe consider some other forms of therapy. Now, these are published articles now from different centers in India of the use of plasma exchange to treat ACLF. The first study is from ILBS. They were looking at the ARC data set in different countries, different centers. The second one is from PGH Chandigarh, and third is from AIIMS Delhi. So as I mentioned at the start, increasingly more and more centers in India are using this. But the question really is, does it work? This is the question in everyone's mind. On the other hand, it seems to be fairly safe to use, and with technology already available in all institutions. So this is an article which is just coming out in JCEH. It's in press now. So when we tabulate the currently available information of the use of plasma exchange in ALF and ACLF, looks like all the smileys are smiling. So they are all seeming to show a benefit, but the benefit is maximally shown in the RCTs or in the cohort studies which have used a single etiology in the group of patients studied. So as I said, the sense that we have in our institution is increasingly, this seems to be improving survival, and we are doing more and more patients on this. So we have a predominantly cadaveric liver transplant program in CMC, and the bottom row is the number of transplants per year. So let's look at last year. In 2022, there were 11 patients who underwent liver transplant, while there were 95 patients who underwent plex. So that's the sort of numbers that we are doing. And our maximal indications for this is for severe ALI or ALF or ACLF. And our commonest etiologies are rat poison, DILI, or alcoholic hepatitis. Now, in Tamil Nadu, in the year 2022, the number of patients who underwent urgent liver transplant for rat poison was 2. That's the number. This is from the government authority. While those who underwent plex for treating plasma exchange now crossed 600. It's now available in almost all district government medical college hospitals. Now, the pathway of when to do plex will differ in different countries. For example, in UK and USA, where it's predominantly a cadaveric transplant program, would be different from Korea and in India, where there's an LDLT option. But in countries where there's no liver transplant option as an urgent option, or access to urgent liver transplant is not available, which applies to most of India, I would think, again, the route, when do we place them, would be different. So this is my last slide. So this is the current way we think where we would place plex now. So let me start with the right-hand side. In ACLF, if a person had grade 1 ACLF, I would say consider plex first. While grade 2 and 3 ACLF, we would first broach the option of an urgent liver transplant. But if it's not possible, or you may want to consider plex first, and then use the dynamic indices of predictors of survival, and then think about transplant. While on the left-hand side, in severe ALI, we would do plex first as the first option. While in ALF, it's transplant is the first option. In a person who cannot opt for transplant, then we would go down plasma exchange. And if those who are not responding, we would go to transplant. Thank you.
Thank you, sir, for an excellent and masterly talk. And do we have questions now, sir? You have to leave earlier, or are you available till the end? 1 or 2 questions, maybe if someone wants, we can have it now on this topic. Any questions from the audience, please?
I'll ask a question.
Okay. Thanks.
Yeah. Firstly, fantastic data, especially the last one of your CMC Velour with 150 cases and very good outcomes without transplant. C-plex versus M-plex. Would it be the deciding factor only in a toxin, which you want to supposedly eliminate, or availability? Or what would you prefer if both are available?
Both options are C and M-plex, you're saying? Yeah. So we have only so far analyzed our alcoholic hepatitis data set, and that's where we found the difference, okay, to say. So, but it's very evident to us that in alcoholic hepatitis, the difference is very clear. So we moved this to all indications and all categories. There are multiple etiologies. For example, we have about 40 patients with viral hepatitis who had ALF, etc., and there we used that. But in every way, we moved to C-plex now. So that's what we've done. In all, we no longer do membrane plex.
Hello, sir. So I have a question. Like you very rightly said, that if a patient with acute liver failure cannot be offered a transplant, then this is a good modality of treatment to be offered. So in this 15%, this 1.5% exchange volume, so what is the amount of FFP that we are using?
So we would always use 1:1. Whatever the volume we remove, the same volume of fresh frozen plasma from a person in health is replaced with.
We tend to use a combination of albumin with FFP.
Yeah, now all of this can be used in various combinations. The American Society of Apheresis recommends that in liver failure to replace fully with FFP. But that's again their expert recommendation, saying that coagulopathy may get addressed by this better. But even the ILBS study, which I pointed out to, they use what you said. They use a combination of albumin plus FFP. We are sticking to FFP usage, fully fresh frozen plasma.
When the patient doesn't have an option of a transplant, then I agree that this is the right way forward. But when the patient is coming for a transplant and we are sort of using it as a bridging therapy and also hoping that maybe a transplant may not be required eventually, in that scenario, I know you mentioned about delta bilirubin, but do you think that based on delta bilirubin, you have a patient who's tubed and he's on plasmapheresis, he has a high INR, and we have to, if we are doing a plasmapheresis, hoping that the natural course of the disease would be such that the liver would regenerate and we would not require a transplant, although we can offer him a transplant in a few days' time. So in that scenario, it becomes difficult to judge because the INR is being falsely corrected. So delta bilirubin, is that?
Yeah. First of all, we are fortunate to be in a center where there is no active LDLT program. So these are all theoretical to us. But these are burning questions in a center with LDLT actively going on. Okay? But we are coming from another planet. So the planet is very different. So two big differences are, one is we don't care about the FFP and INR because that's no longer there. The second big difference is we do not sedate. That's a massive big difference. Okay? So because there is no transplant option. It's another planet now.
Right.
All right? So then we say, why should we sedate? Because we know all sedatives are metabolized in the liver. If I give 1 mg midazolam, it's like giving 5 mg midazolam. So that's one comment I want. So there are two big differences we have done that. And we think that's also part of the reason why people are surviving, because we're not sedating them. But specifically answer your question, these are serious and massively very difficult questions to answer, but we need dynamic predictors of survival. So if bilirubin improves, I think the liver is working better. That's one way. That's how. It's not that bilirubin is coming out in the plex filtrate. That's what we're using that. So I think yes, we'll have to derive some parameters. So if it is MELD, the problem is INR is coming in there again. So it is largely bilirubin. So these are just early days. Surely it will come, dynamic indices of survival, which has to guide our treatment option. The study from Europe, there were a good number of patients who couldn't get urgent transplant. That will remain even in active LDLT programs in India as well. So then in that group, think about saying this 180-degree shift. So we're trying not to tube the patient, because the moment we tube, we need sedation. We have to, then that goes another route. So these are my thoughts on it.
Thank you.
Good afternoon, sir. Thank you for the good talk. Sir, my question is actually in plaques, what we are doing is removing the inciting agent like rodenticidal poison, and plus with cytokines also we are removing, and dams which formed during the acute liver failure. So, and sepsis also we have to remove before doing plaques. So, can we use steroid in between? Because many patients, they have improved LFT after plaques, but again it started deteriorating. So, this is my first question. Second is in ACLF.
So I'll take one more question, otherwise I'll lose my train of thought, if you don't mind. Yes. So in our protocol, every patient gets steroids, every patient.
Yes.
And we give homeopathic dose steroid, but it seems to work very well. So we would start the steroid from the day before plex. Okay? So tomorrow is plex, today we start with 10 milligrams of prednisolone. That's what we do. So whatever the etiology is.
Yes.
And it's again derived working over time only now, over last few years. Seems to work very well. So every patient gets low dose steroid, and we can discuss that why are we doing that or not. That's another.
So can we give IV steroids in that case?
The person not able to take orally, we would give IV equivalent of 10 mg prate.
High dose, sir. Like
we give only 10 mg prate because always the worry is, will you tip and make a person go into bacterial infection? That's our concern. Okay. If there is, we stop plex.
Yes,
so
sir.
we don't give high dose steroid. We do not give high dose steroid.
Thank you very much, sir. So running short of time. Now we invite the next speaker, Dr. Shweta Singh Max, Super Specialty Hospital from Saket, to talk on role of intensivist in acute liver failure.
Thank you. So I would like to speak about the role of the intensivist in the management of acute liver failure, and I'm glad Dr. Ipan is here. So first of all, I would like to present a case, one which we shifted out of the ICU this week. This was a 17-year-old male. He had a history of fever for last 7 days and jaundice for 5 days when he contacted us. And he had he was gradually going into altered sensorium, and we asked him to shift in. So once he came in, and these were the reports that they came to us with, that there was a high bilirubin with elevated enzymes and INR of 6.8 and a normal renal function. When this patient came to the emergency, he was gasping, he was in altered sensorium, he was tubed in the emergency. They needed a high FiO2, high PEEP to maintain his saturation. The pupils were reacting. The blood pressure was low, so they started inotropes, and he was shifted to our ICU. In the ICU, the vitals were being maintained on inotropes. The airway was already secured. We had to ventilate him with 100% oxygen using a very high PEEP. We had to knock him out completely in order to synchronize the ventilation, because oxygenation was also a concern. I would like to ask the audience, what would you do in this situation? Of course, besides standard medical treatment, would you consider a transplant? If you had the option, would you suggest a transplant? Well, he was suggested a transplant, so that is the reason he came to our center, because ours is a center where transplant is available. So there is a patient who was being treated conservatively in another setup. They suggested a transplant and shifted him to us. But by the time he came to us, he was having very high oxygen requirements. He required knocking out, sedation, and paralysis for maintaining the saturation. And here we have a patient, and once we did the labs, we found the ammonia was 288, and he was having an etiology of hepatitis A. So we continued the sedation. We did the necessary ETCO2 and other monitoring to maintain because our focus was to manage the hypoxia as well, and the temperature and the vitals and the ICP monitoring with 2-hourly pupils and ONSD. And for all these things, you require an intensivist, you require an ICU. We started him on the antibiotics. We also started anti-epileptics. In this case, the patient was also paralyzed. We started all the sodium correction, sugar correction, nutrition, and we decided to filter using CRRT for the high ammonia, although the urine and the renal functions were fine. For placing the lines, we did a TEG, which was okay despite the rise in INR. And through the course of treatment with the CRRT, we were able to filter, and gradually, since the pressures were not very low, it was okay to do the dialysis gradually, and it was seen that the patient's oxygenation was what created the major problem. So we had to, when we are ventilating with 100% oxygen, PEEP of 14, we had a great deal of difficulty in maintaining his oxygenation, but gradually his liver function started improving on CRRT. The lactates had started declining right in the beginning. The bilirubin was coming down slowly. But the most important thing which we used was the INR to say that the patient was responding to filtration. This filtration, again, I will say, was started not for the renal parameters, but for the fact that we were trying to give him a therapy in which we could bank on the INR for telling us whether this patient still needs to be transplanted. And subsequently, we struggled so much with the oxygenation that we had to prone this patient. So these are the kind of things that only an intensivist can do, and that is where the role of the intensivist comes in. So we all know that acute liver failure is failure of a liver, but it is a potentially reversible condition, and it can lead to multi-organ failure and death. So I am here to justify the role of the intensivist in management of acute liver failure, which involves all the organ systems. And we know that with passing time from the West as well as from the East, there has been report that as the understanding is improving, as the level of care is improving, there has been an improvement in the outcomes of patients with liver failure with intensive care management. And this has been possible with better staffing, better care, better modalities for treatment. The etiologies are different in different parts of the world. In India, it's mostly viral. DILI and CAM is also very, very responsible, and as like Dr. Ipan said, rat poisoning. So all these etiologies need to be treated and understood and managed accordingly. In our setup, depending on whether the patient is presenting as a hyperacute case or a subacute case, the challenges are different. And that is how, depending on how the patient is progressing from jaundice to encephalopathy, whether it is a hyperacute presentation, whether he has a fulminant cause where there is a lot of cerebral edema, no doubt that these patients may have a spontaneous recovery, but they will require intensive care management, they will require organ support, they will need ICP monitoring, they will need measures to reduce their ICP. On the other hand, you have subacute presentations where the patient has a long drawn-out course, where he needs a lot of organ support, and sometimes these patients need to be bridged to a transplant, and after the transplant, there is a long story of how to manage the post-transplant course, for which again you require an intensivist. So the intensivist's role is to support and optimize conditions so that the liver can regenerate. He can identify which candidates require a transplant, bridge to transplant, and even manage the post-op course. We know that these patients can succumb to cerebral edema, especially in the hyperacute phase, which can resolve on its own. Then sepsis is a major killer, and renal failure. So, since cerebral edema is the most important thing and which has to be managed, and as the grade of encephalopathy worsens, we need to intervene. So these patients need to be monitored and taken care of in the ICU. It has been shown, there is multiple literature over decades that invasive intracranial pressure monitoring is not being used. More and more centers are moving away from it. In India, I don't think anyone uses it. So we have to rely on a combination of non-invasive ICP monitoring. In those, if you are looking at the level of consciousness, if you're looking at pupil responses, if you want to just look at posturing and seizures, you can monitor the patient in the ward, and maybe you will have to. But it would be helpful if this patient was in the ICU and you could see the level of sensorium dipping, decide when and where to intervene. In our ICU, we use the NPI, which is the monitor which has no subjective variation. So the different staff can monitor the pupillary reaction every 1 hour without any subjective variation, and we can actually see whether the patient's, whether it's a brisk response or slow response, even if the pupils are sluggishly dilated, sluggishly reacting, those changes can be better picked up. These things are only possible in the ICU. We have seen that there are sporadic case reports. This was one of our experiences, and many of us face these problems, that these patients will suddenly develop dilated pupils and you do not know what to do. So in those scenarios, you can see the pupil, you can see the fundus, but it's a fact that when you're monitoring these patients, when you're managing these patients, these situations will arise where the pupils are fixed and dilated. So do you give up treatment? Do you stop planning for a transplant if you were planning? So in those cases, you require more intensive monitoring, because in every case, you can't drag the patient down for a CT. And even fundus monitoring tends to lag. You cannot rely on it completely to see whether there is papilledema and if the patient has herniated, and you should stop all treatment and tell them that this patient is gone. So for these kind of things like jugular oximetry, where you put in a catheter through the IGV upwards and you monitor the arteriojugular venous oxygen difference, and you see whether the oxygen consumption is going down. Again, not one of our preferred modalities, but this is something which can be used intermittently for monitoring the course and the direction in which the patient is going. You can do optic nerve sheath diameter. Optic nerve sheath diameter, since it's in direct continuation with the intracranial space, it gives you an idea of which way the patient's ICP is going. There is a probe which needs to be kept on the eyelid, I think everyone knows, and then you see 3 millimeter behind, and you see the change in the optic nerve sheath diameter, and you can see whether this patient is developing any changes of raised ICP, and you can decide whether you want to up the treatment, do you want to intervene, do you want to manage this better. And now, there is also transcranial Doppler, which has been there for 10-15 years, I would say, where you measure the middle cerebral artery flows, and you can see that there is a systolic element, and there's a diastolic element, and there's a pulsatility index and a resistive index, and total flow velocities which are seen, which can tell you by serial monitoring whether this patient, which direction this patient's cranial pressure is going, and whether this patient is improving or it needs further action. EEG can be seen to see whether there is whether this patient is seizing subclinically, because sometimes you do not come to their subclinical seizures. You can see the pattern, but this is not something which you can do continuously. You can do it once, maybe in the ward, but you can't, monitor the patient continuously with this. Now coming to infrared spectroscopy, which is another new thing. So using a combination of these three things, which is the biggest killer in a case of ALF. These are the things which you can monitor serially in an ICU, since you are looking at 1:1 or 1:2, and sometimes in some ICUs maybe 1:3 nursing, but still it is possible to monitor the condition of the cerebral edema and take action. We need sometimes to decide when to intervene, when to secure the airway. This airway could be required, securing would require for airway so that the patient does not aspirate. It could be for the control of agitation. You cannot just knock out a patient and then not secure his airway. So these things are taken better care of in the ICU. And then you give certain drugs to secure the airway so that the ICP does not rise at the time of intubation, and you use lung protective ventilation strategies like we did, where you use low levels of PEEP. And definitely you need to knock out the patient, otherwise he will not tolerate the tube. And if you feel that the sensorium is obtunded to that level that he will tolerate the tube, then the chances are that he will aspirate, so he will require a combination of these things. And then there is a role of monitoring with BIS. Now, if you feel that you cannot monitor with BIS, it is perfectly safe to use low levels of drugs which are not metabolized in the liver, like propofol. Remifentanil is another drug which is variously used because it uses a different metabolic pathway and it can be eliminated from the body. But we do not have remifentanil in India, but we can use fentanyl. So fentanyl and propofol is a combination which is used for sedation of these patients. Yes, we do not want to paralyze them, because if we paralyze them, then we cannot observe for seizures. There is no way of knowing that these patients are having any manifestation of raised ICP. The posturing will not happen. But it is important to sedate these patients with a little bit of propofol, which does not get metabolized in the liver. The other thing that is done is tracheostomy. So, like the case that I had demonstrated, when we were struggling with the oxygenation and ventilation of this patient, we had to choose between PEEP and a tracheostomy. So, once we realized that this patient is deteriorating, we had, from the oxygenation point of view, we tracheostomized the patient and we proned the patient. So again, proning is another thing which is very, very dicey in a patient with liver failure. But a patient with liver failure, if his liver starts improving, then there can be other situations which need to be handled, like the lung in this case. So we had to prone the patient. Can I continue? Thank you. Then CRRT is, which for the specific management of cerebral edema, we need to do measures which can only be done in the ICU, like ammonia clearance with the help of CRRT, which has been shown to be very useful, and this is what we rely on. And in the pediatric setup, there are actually indications which have been given for the implementation of management of ALF and using CRRT. Now we know that there is no role of hypothermia in ALF because of the problems associated with hypothermia as well, like coagulation disturbances and arrhythmias, and there are trials to show that we do not want to cool the patients too much, but we have to tackle the fever and we have to maintain the temperatures. So it could be around, maintaining a temperature of 32 to 35 degrees Celsius definitely helps, although these studies have shown effectively that we don't want to, really cool the patient down. And sepsis management also needs to occur because sepsis is the next killer, especially in subacute liver failure, where once the patient's liver starts recovering, you find that the patient is on supramaximal doses, has gone into septic shock. So the infection needs to be managed proactively, maybe with broad spectrum antibiotics and other things which Dr. Puri will be talking about. So hemodynamics is another thing which needs to be managed in the ICU, and again, that is the role of the intensivist to see whether the heart is affected or is the volume depletion or is sepsis or things like we use the passive leg raise test and we use the flow track monitor. We assess the stroke volume variation. We see the IVC diameter and we decide how much volume to be given. So these are the things which are better done in an ICU and the role of the intensivist hence. which inotrope to use, management of lactic acidosis with volume depletion. If the patient is volume depleted, you will initially get lactic acidosis, but once you repleted the volume, then and maintenance of nutrition with enteral feeding. You want to secure the airway, but you want to give enteral feeding. If the patient is on high inotropes, you may not want to give enteral nutrition because it will not get absorbed. So these kind of decisions on whether you can give component parenteral therapy to tide this phase, dealing with the coagulopathy when you are having to place the lines, doing TEGs like we did one for assessing before we put in a hemodialysis catheter for filtration. Renal dysfunction, if it sets in, use of CRRT to manage that. So CRRT we feel is an expensive modality, but it helps in every which ways to tackle these patients, because not only does it help to lower ammonia, if renal dysfunction should set in, it helps to tackle that. It also helps in correction of the sodium better. You can't, if you're giving hypertonic saline and you're doing CRRT, you might as well correct the sodium with the help of CRRT. You can manage the patient's temperatures better. So there is a role of plasmapheresis, which Dr. Ipan has already talked about. He's talked about Larsen's study, he's talked about Raki's study. So I would like to conclude by saying that acute liver failure has definitely got a very high mortality. It could be from cerebral failure, it could be from sepsis, it could be from renal dysfunction and all the problems that happen with it. So there is a role of the intensivist. Thank you. These are some of the patients which we've cured without transplant with acute liver failure, and it's definitely a very rewarding experience. Thank you.
I think we overshot the time, so we'll cancel the questions. Are you okay with that?
Yeah.
So, thank you.
Now, invite Dr. Pankaj Puri, Fortis Institute, New Delhi, to deliver the talks.
Thank you, Chairman, sir. Good afternoon, ladies and gentlemen. Shweta, you're not losing your job. What I'm doing is also your job right now. So I'll be talking on managing septic shock in cirrhosis. Septic shock is happening in almost 6% people. 30% will have sepsis, and septic shock will develop in 6%. Mortality in septic shock in cirrhosis is high, going as much as 78% in this study. Some of the issues which I'll discuss is how do we assess the volume status? What should be a choice of resuscitation fluid? Is there a role for 20% albumin beyond fluid resuscitation? The choice of vasopressors, goal of blood pressure, the role of steroids, and the choice of antibiotics. These are my top 7. Volume assessment is always a challenge. Patients have edema, ascites, they may be on beta blockers and have a low pulse, and the BP will also be lower. The CVP can be falsely elevated in ascites, and tests like IVC diameter and passive leg raising may become unreliable if there is intra-abdominal hypertension and tense ascites. The large ascites is also going to impair the IVC collapsibility index, and the stroke volume variation may not be of any value if the patient is spontaneously breathing. So we would like to have the patients in central lines and arterial lines. Some of the dynamic variables are preferred, including what Shweta has mentioned about passive leg raising, stroke volume variation, the IVC diameter. Pulmonary artery occlusion pressure is invasive and rarely used. IVC variability will depend on whether patient is on mechanical ventilation or is in spontaneously breathing. Initial echo is done in most patients to look for regional wall abnormalities, look at the internal diameters, and look for evidence of hypovolemia. Some of the indirect markers of tissue oxygenation like lactate trends may help guide volume status assessment. So we use the echo initially and keep pulmonary arterial pressure monitoring only in case of persistent hemodynamic instability, and as I said, we rarely use it. If there's tense ascites, it may be worth considering removing the ascites because it's contributing to intra-abdominal compartment syndrome and decrease respiratory compliance and renal and cardiac dysfunction. Second would be the choice of resuscitation fluid. While large randomized controlled trials have not demonstrated an advantage of colloid over crystalloid resuscitation, some subgroup analysis suggests the beneficial effect of albumin. There are two studies, both of these have been done from ILBS, which is the FRISK study, which I'll cover these a little later, which shows that there's higher hypotension reversible with 5% albumin. And the second study was on 20% albumin, which is called the ALP study, also showed faster hemodynamic improvement. We should avoid starch because it's associated with higher mortality and higher renal failure. The Society of Critical Care Medicine is recommending albumin for resuscitation fluid in patients with ALF, especially if the albumin levels are less than 3 milligram per deciliter. This was the study, which is the FRISK study. They had compared 5% albumin and normal saline for resuscitation. If they had 308 cirrhotics and randomized them into 5% albumin and normal saline, and the primary reversal endpoint was reversal of hypotension at 3 hours. The patients who had 5% albumin had higher reversal, and the indirect markers like sustained reduction in heart rate and lactate improvement was better in the albumin group. This is the second study, which is the 20% albumin. And they compared 20% albumin versus Plasma-Lyte. They found that albumin was superior, but there were higher pulmonary complications, and the treatment had to be discontinued in about 22% of the patients who were on 20% albumin. So if we have done a resuscitation, is there a role of 20% albumin beyond resuscitation as well? So definitely the role of albumin has been documented in patients with SBP. It decreases the incidence of HRS. Now, this was the RCT, which was efficacy of albumin treatment for patients with cirrhosis and infections other than SBP. And this aimed to assess if albumin improved survival in patients who had infections other than SBP. They used 1.5 gram per kilogram on day 1 and 1 gram per kilogram at day 3. So while the mortality was similar, a higher proportion had ACLF resolution and a lower proportion had nosocomial infections. So that was suggestion that it may have some benefit. Now these are some of the trials of short-term albumin for bacterial infection, and I'm just going to cover the last one, which is the ATTIRE study, which was a randomized controlled open label study of 777 patients, with 380 had human albumin and 397 had standard medical therapy. And they were targeting 3.5 gram per deciliter of albumin from day 1, and albumin level who had albumin levels less than 3. And there was no difference in new infections, kidney dysfunction, sort of like this. So they had no improvement by giving albumin. Some of the negative things of the study were that the dose used was lower, and there was limitation in the design, that was short-term administration. They excluded ACLF. And some of the patients in control arm also received albumin. But overall, this was the editorial which accompanied it, which said albumin infusions and decompensated cirrhosis no longer the elixir of life. So there may be some role of albumin, 5% in resuscitation. 20% for resuscitation I would avoid. 20% for infection and preventing deterioration, role is still, the jury is still open. The next is the choice of vasopressors. Noradrenaline is the preferred choice. Dopamine has higher adverse effects and all cause mortality. Vasopressin is, while it's not the first line of therapy, it is often used in conjunction because of additional hemodynamic effects. There is a study which was done in 2016 by Chaudhary, which showed that terlipressin may be as effective as noradrenaline, and it had additional benefit of preventing variceal bleed as well. What should be our BP goal? This was a randomized controlled trial, which is target C of high versus low mean arterial pressure. This was again done at ILBS. There are 150 patients, And they randomized them into people with a higher target of 80 to 85 versus a lower target of 60 to 65. And they found that a higher mean arterial pressure target did not confer a survival benefit, but it did improve tolerance to dialysis, lactate clearance, and renal recovery. People who had a higher target had higher adverse effects, and dominantly these were digital and mesenteric ischemias and arrhythmias. So my take from this would be I would target 60 to 65, but if the patient is going to need dialysis, probably the target should be revised to slightly higher. What about the role of steroids? The role of steroids is still not settled, and the Society of Critical Care Medicine is recommending that in refractory shock when vasopressor treatment is not effective. But there is a high evidence of adrenal insufficiency in these patients, and it's reasonable to use steroids in patients if we are suspecting adrenal insufficiency. One of the ways is to initiate hydrocortisone treatment after giving a sample, and if the tests do not show adrenal insufficiency, you could consider stopping it. But it's the refractory shock, take a cortisol sample and give steroids. The last question which I will address is the choice of antibiotics. See, the pharmacokinetics of antibiotics are altered in septic shock, in cirrhotics, this portosystemic shunting, which leads to lower first pass effect. There is ascites, which affects the volume distribution. There's low peak and high half-life. There's decreased liver mass and function per se. There's decreased liver flow and a decreased albumin binding. And there's displacement by bilirubin. So lots of things are affecting albumin. And if we need, some of these drugs need to be modified. For example, the commonest drug which is often used is ceftriaxone. 30 to 60% of this is biliary excreted. We must consider dose adjustment, not going for the very high dose in people with severe liver disease or renal impairment. Ciproflox, levoflox do not need any modification. Moxiflox needs to be avoided. Some of the other drugs is aminoglycosides we avoid because of toxicity. Even metronidazole, which is used, recommendation is to have increased dose interval in severe liver disease. Unlike renal modification charts, there's no hepatic modification chart. So there's nothing which, on the basis of which we just need, often there is concomitant renal infection, but we must be aware of the drugs which need to be modified in liver disease as well. So empirical antibiotics will also depend on what the choice, what the suspected infection is. That also needs to be considered. So to conclude, I will say that volume status assessment in cirrhosis can be challenging. We would have dynamic variables would be preferred. We should assess the resuscitation, the ideal resuscitation fluid may be 5% albumin, which we should consider. 20% albumin may have higher adverse effects. The value of 20% albumin to prevent infections beyond resuscitation may be questionable because of increased toxicity and side effects. There is the optimization of vasopressors should be done, and noradrenaline is the first choice, adding to vasopressin if required. Consider steroids for adrenal insufficiency. Take a sample of cortisol and give a shot of hydrocort if you suspect and patient is not responding to and is on high dose vasopressors. Appropriate antibiotics suspecting the infection, modifying for kidney infection, and looking at what the drug metabolism in the liver is. These need to be considered to salvage the patient. With that, I will complete. This is our list. This is a group of doctors at Fortis Escorts, New Delhi. Thank you.
That was a wonderful talk, especially considering you saved the organizers 4 minutes. So
I'm going to leave all the job to the intensivists. She's not losing her job.
So, but any questions from the audience?
Yes, sir. Sir, regarding the resuscitation fluid, like if the patient comes into the emergency, you know he's a cirrhotic under your follow-up and he comes to the emergency looking septic with a blood pressure of 70 systolic. So the antibiotics that you showed would it be nowadays? Would we just rely on those, or we just directly jump onto the carbapenems? And what would be your fluid of resuscitation in that case?
Obviously, if the patient is in septic shock, you're not going to give ciproflox, or you're not going to give ceftriaxone as your first line therapy. But sometimes these may be indicated depending on what we have grown on culture. If you're giving blind therapy, you'll probably go to a combination of either a quinolone with clavulanic acid, cephalosporin with clavulanic acid, or a piperacillin tazobactam, or a meropenem. You'll go to one of the higher levels if the patient is presenting straight with septic shock. But once you've grown the bugs, you have to modify them accordingly.
In the emergency, what would be your first choice in the current era? Like what, the fluid and the antibiotic?
Antibiotic first shot would be at least a Magnex, minimum minimum a combination of cephalosporin with the clavulanic acid. That should be the minimal one. If you really have a very sick patient, we will go straight to meropenem group. And the second question is my choice of fluid resuscitation. You'll start with saline. Once you shift the patient to the ICU, you will consider 5%. Also look at other things like chloride. What's the intensivist going to do if you're going to cover all that? She's out there. You look at the chlorides, you look at the other things also while choosing the fluid.
Dr. Puri, will you do echo in all such patients at presentation to look for hypovolemia?
Every patient who comes to us with shock should have an echo. You will be surprised that some of them may have other issues. There may be regional wall motional abnormalities. What do you think? The patient is fluid overloaded. Some of them may be actually having heart failure for all you know, which may be adding to the shock.
No, but at presentation you do echo, or you plan it in a subsequent day or so?
The patient shifts to the ICU, gets the echo done in the ICU. He's not going to get an echo in the casualty, but needs the echo on day one.
Sir, in patients in ICU with CLD patients, decompensated, in normal patient we advise the mean arterial pressure more than 60, as you told, but in CLD patient, shall we maintain at more than 70, as some studies have shown?
So this was this study which I showed you, which is from ILBS. There has been some debate on what is the ideal blood pressure. But there's no difference in survival between 60 to 70 and a higher mean arterial pressure. The only thing is, if people who need CRRT, they will tolerate it better if you're maintaining higher blood pressure levels. If they don't need renal replacement therapy, then 60, 65 may be adequate. As you give higher doses, you'll find that tips of the fingers are becoming black, they'll get abdominal pain, they get mesenteric ischemia. And you're not really adding to any benefit by going to levels of 80, 85.
Okay. Thank you, sir.
So if there is no further question, I think we can conclude this session. Thank you, Dr. Puri, and rest of the speakers for the excellent talks.
Thank you, chairpersons and speakers. The wonderful talk. It was the penultimate session. We come to